if you were coming along now, if you were just getting out of your residency and were getting into your career, what would it be like for the young Jim Leyden in 2023?
Well, there's no question I would be at the NIH for the next 5 to 10 years, and I'd be trying to learn as much as I can about the genetic aspect of disease and the technology that evolves that's going to allow the modification of gene expression that will be the treatment. We won't be talking about, do you do this, do you do that? We're going to be talking about how to, I can see a couple hundred years from now, people in private practice will be doing gene therapy in their office. The technology will develop. And
so with the advances and so many advances in technology, there's so much information that comes out where I think a lot of people struggle, especially clinicians that are more removed from what's actually going on. How do you separate the noise from something that's really important? Let's say you're looking at the pathophysiology of a disease or some of the things that you're talking about, gene therapies. It's so hard to separate what's just noise from what's really going to be clinically relevant.
Yeah, well, I think a large part of the responsibility comes in departments of dermatology, whoever's, whatever group is at an institution, to be able to have enough people who are actively involved in enough fields that you know that within your department you have a person or a group of people who are expert in skin cancer, melanoma, psoriasis, eczema, acne, whatever, so that you in that department know that you as a department are able to keep abreast of these tremendous widespread differences, and that you make sure that the people who are in that residency program and people who come to the weekly grand rounds programs keep abreast and can count on what they hear as being as good as interpretation as we can make, and not anybody trying to sell you something,
right,
or somebody who is professor or gives, this meeting I just was, there was one guy I was really happy to see, because it was a symposium in which nobody was in the audience, which was just fine with me, because I didn't think anybody should listen to him, quite frankly.
There are a few.
You have to have solid sources of information, and you have to have enough people working in a field so that they can know pretty much everything that's going on in that field. And because you're interested in another area, you can't possibly be following that field. Now, when I was starting, I could follow everything because there was nothing, and every little new thing, it wasn't overwhelming. But now it's overwhelming to try and become really expert in the wide number of things that our specialty has gotten so good at.
I'm glad I wasn't that speaker in the room that you're talking about. You don't want to be, you try not to be one of those people. But I have another question for you, because I know that you were very close to this and involved with it. I'm trying to picture 1965, everybody's clamoring around, from my era with the Beatles and the Rolling Stones, and you're deciding whether you're going to develop the MRI or develop drugs in dermatology, treatments in dermatology. But what about tretinoin? I know you were very involved with that. I understand has a great history.
Story. It's a really wonderful story, because the story starts in Europe with Hoffman LaRoche. There was a basic scientist named Bolag, who was his area of research interest was two-stage chemical carcinogenesis. And he stumbled upon finding that, as it was known in those days, vitamin A acid, now tretinoin, had a profound effect on interfering with chemical carcinogenesis. And since he worked for a pharmaceutical company, they're always interested in what molecules may have to do with disease. So it was clear that this molecule was influencing the normal cellular operations of the epithelial tissue. So they decided, well, maybe it'll have some effect in skin disease. So they went to the University in Berlin and collaborated with a dermatologist named Stutkin, who I got to know. He's a wonderful, wonderful guy. He's dead now. So he said after he was dead, I could tell this story. When he was during the Second World War, he was a physician in a prisoner of war camp. And he took such good care of American prisoners that they subsequently brought him back to America and honored him and brought him back for various visits. He was so embarrassed that he was part of that. He said, please don't tell anybody. I said, how about when you're no longer here? He said, well, in that case, you can tell whatever you want. He was a wonderful guy. So anyway, he started using this vitamin A acid, and they were reporting it looked like it had some benefit in some forms of ichthyosis, Darier's disease, and other so-called disorders of keratinization. So Roche filed for a patent, and in the patent, they specifically said that vitamin A acid did not work in acne. That was a negative finding, which strengthened the fact that it looked like it had ability in several skin diseases, but it wasn't like it worked, and there was nothing that it didn't work in. So I always remember, and that the guy who was the head of that department was Orfanos, who was part of the patent application. And Albert said, that son of a bitch has never been right about anything in his life. We're going to look at this goddamn vitamin A acid because it probably works in acne. If they say it doesn't work, it must work. So that was the genesis. That's what. Okay, now the unbelievable part is, so who's going to look at it? Well, it's going to be this guy Gerd Playwig and me. Gerd had started his fellowship the day I started working with Marples and Kligman. And so here we have two, well, I guess you could at best call us neophytes. We were like, we're in dermatology for a month, and we're now in this acne clinic that Kligman got funding for. And he's giving us stuff that comes in various bottles to try this, try that, not just vitamin A acid, but all kinds of things. After about 6 months, Playwig and I, we were absolutely 100% sure that this one stuff called vitamin A acid really worked. We had pictures where we were treating half the face, half the forehead clear, and the other half full of pimples. So even though we were beginners, we were sure. So Kligman was absolutely thrilled, and then all of a sudden, after another 4 or 5 months go by, we say it's not working anymore. And he says, what do you mean it's not working anymore? I'm in the process of filing a patent for the department, and you're telling me now it doesn't work? We said, well, it doesn't look like it works anymore. So it took us another couple of months to figure out that the reason it wasn't working, it was now being given to us in clear bottles. And previously, just by chance, it had been in dark bottles. And we eventually, after thinking about it and doing some more work, we found out that this molecule was photolabile. So if we had initially studied it in solutions in a clear bottle, we would have confirmed the findings of Stutkin and Bolag that it didn't work in acne. So
it's unbelievable. That is unreal.
Then when it was launched, because it was a hydroalcoholic solution, it was 100% bioavailable. So the irritation potential that we all know exists with retinoids, and some patients more trouble than others, was a horrendous problem in those who had a problem. I was talking, I won't tell you where because you'd probably figure out who it was, and to a dermatology society annual meeting and about acne, and I was somewhere in the sebaceous gland when the person who was the head of the department of that major program in the area jumped up and said, I can't take it anymore. I have to get this off my chest now. And the audience, of course, went silent. And he said, this crap you and Kligman are saying about vitamin A acid, it has to stop. It's outrageous, blah, blah. And I said, well, I haven't mentioned the word vitamin A acid yet. When I get to treatment of acne, I did plan to mention it as part of the overall approach that we believe is rational and effective. And he kept getting more and more upset, and the audience was getting very, upset because you don't usually attack the guest speaker until he's finished the talk. So I said, I'd be happy to stay over tomorrow. We could talk about this more in detail. And he said, he just exploded. And then, so I finally had enough. I said, well, I've taught some not very sharp residents how to use this. I don't see any reason why you couldn't figure it out either. And he left the room. And it was with the advent of systemic retinoids, with the tretinoin in psoriasis and isotretinoin in acne that were clearly very, very effective, particularly isotretinoin in acne, that nobody could say, well, these molecules are not something that we need to be understanding better and developing further.
So, Jim, I have something to ask you about isotretinoin that I know we've crossed paths on, fortunately, at least from my perspective in the past, and I find that a lot of dermatologists still struggle with this because, patients, even with lower doses, and you and Strauss and others showed this years back, could clear, but keeping people clear depends on how much they're getting systemically. And it really wasn't talked about that you need the fat. You need the fat, right?
I don't totally agree with that. Here, let me just tell you what I'm pretty sure I know. When we first started working with this molecule, there were several miracles that happened. First of all, these people with very bad acne that at that time, the best we had was dapsone and minocycline, and with at best moderate control. These people were completely clearing up. The other thing that happened was these people stayed clearer for quite some time. A key point was that all of the patients that were in those early studies that Strauss and Pochi and Alan Shalita and I were involved in were over the age of 18. And they were over the age of 18 so that they could personally give consent, and there would not be their parents giving consent. Okay. And that it was a crucial aspect of why so many of them stayed clear for so long, which I raised in the early 80s. I said, I said some things that people thought I was crazy that turned out to be pretty good. I said, this treatment reminds me of X-ray. I'm old enough to have actually treated people with X-ray. X-ray, we now know, induces apoptosis. It shut down sebaceous glands. And we had learned before there was ever a glimmer of an idea like isotretinoin, we knew that that X-ray treatment of bad acne was like 100% effective. It cleared everybody up. And we also knew that we learned that if they were old enough, meaning they were in their late teens, early 20s, that they almost never had the acne come back. But if they were treated when they were 14 or 15, it very commonly came back. So I said, this treatment reminds me of X-ray treatment, and it may be that there's an important age-related factor in terms of how long a treatment lasts. Now, we had a very important meeting back in the early 90s in which there were Alan and I, Shalita and I were the U.S. representatives, and Bill Cunliffe and Jean Revus, a whole bunch of people from Europe and Scandinavia, and we sat around, and out of that meeting came the best course of treatment to make patients stay clear was 150 milligrams per kilogram total dose. I got outvoted 12-1. I said, this is nonsense. We're just making this up. I think there's an age-related factor that needs to be at least investigated. And so I got outvoted, and that's where the total cumulative dose comes from. It's made up, pulled out of the air by Bill Cunliffe, my very good friend Bill, pulled it out of the air. Everybody but me voted for it. Subsequently, and you'll remember this because you and I, it was a meeting you put together updating isotretinoin some years ago. I presented some of the age-related relapse data out of the iPledge data, in which we had 30,000 patients who were treated by dermatologists all over the country with whatever they treated them with, whatever dose. We couldn't standardize that, obviously. But we had follow-up data, and we took as a relapse point, a crisp point, as if you're back on the drug, then you've relapsed it probably at least to where you were, if not worse. And when you look at that data, there's no question. There's no question that their age is the most important factor, and which we're not going to be able to discuss this here, but I've been thinking about things for years, like why does acne go away? I think I know why it goes away now, but it would take a long time to discuss that. And it's given me some ideas, some I think really good ideas of why certain people get acne and other people get maybe a few pimples, but not enough to see one of us. So the idea of how much you need to give somebody, for me, is now very, very straightforward. First of all, I don't think women need, very uncommon.
Well, can I stop you right there and say, do you?
Yeah.
Because a lot of that was based on the older formulation that was very lipid dependent with the meals. Is that a factor also in the long-term outcome?
That's a factor on dose, on actual dose. So you alluded to it earlier. In the early studies, the dose ranging studies, we could not find the non-effective dose. It wasn't
to get people clear, but what about staying clear?
Well, where did the staying clear come from? Listen, when I first presented something at the Academy, and I showed everybody who was in the study before and after, and the audience went berserk with applause. And then I said, and believe it or not, these people are still clear. Well, everybody said, wait a minute, what have you been drinking too much? That can't be possible. They can't stay clear. That's ridiculous. Well, everybody found out that wasn't ridiculous. But the question, so then it became, well, what's the best dose to make sure you only have to do this once? The only person who said, hey, I don't know, that focus is okay, but it shouldn't be the focus. We should be looking at other factors like age. So now that we know, that I know at least, and I think some others now agree that age is such a major factor, when you use that drug, my advice, my approach is you find the highest dose that patient can take without any side effect issues. So, and once they clear up, I've adopted, without any evidence for why it's 2 months more, just something I plucked out of the air. It could be maybe 3's better, maybe 1's enough. Maybe you don't have to do it at all. I don't know. But I do it to make sure they stay clear, and then I stop. If their acne recurs down the road, then I treat them again, same way. So I believe in no side effects or minimal side effects. Clear, stop, retreat if you have to. I think it's uncommon to have to treat women, girls. I think that they if they don't do well, my approach is you start everybody on a retinoid and benzoyl peroxide. If in 4 months they're not really clear, then you move on. In males, you move on to isotretinoin, dosing the way I just discussed. In girls, you move on to spironolactone. If that's not enough, you add estrogen. And it's uncommon to have to go to isotretinoin. It's very uncommon in my experience. There are some, but not many.
So you don't think the dietary aspects in terms of how much is being absorbed is a factor in that, right?
It's a factor in terms of what their actual dose is. Yeah. And it may well, if they did it with, if they had took it with fat and or they took a formulation that is partially solubilized, they might clear up faster. I think it could be important in that, but I don't think, once you clear up, you're cleared up.